one of the neurology. Okay. Okay. Let me introduce our speaker today. He is Professor Johil Haq Choudhury. He's the Professor of Neurology, currently working in National Institute of Neuroscience. Our today's topic is thrombolysis for management of hyperacute ischemic stroke Bangladesh perspective. It is very interesting and time-demanding topic, I would say. Let me introduce our panelists today. We have got Professor Naran Chandra Kundu. He's a professor and head of Department of Neurology, currently working in Shahid Sohrawardi Medical College, Dhaka, Bangladesh. And also we have got Professor Kazi Mohibur Rahman. He's a professor and head of Department of Interventional Neurology in NIMS, Dhaka, Bangladesh. Before starting our program, I would like to say some housekeeping rules. If you have any questions, any concern, any issues, you can give me a shout. You can drop a message in the chat box. You can just raise your hands. Our program is going to be live in Facebook as well, so you can drop message there as well. And I hope that we'll have a good discussion at the end of our talk today. Okay, so I think we can start our program. Over to you, Professor Dr. Johil Haq Choudhury.
Thank you very much, Sabia Nadia Mujumdar, for introducing me and start for our team program. Respected chairperson and our panelists, Naran Chandra Kundu sir, Professor of Neurology, and Professor Mohibur Rahman, panelist of this program, and my dear audience, Assalamu alaikum. Today, my talks on thrombolysis for management of hyperacute ischemic stroke, Bangladesh perspective. Definitions of stroke and transient ischemic attack and ischemic stroke. We all know about the definition, and the symptoms of stroke is a synonym. Be fast. B means balance. Sudden onset of the imbalance is known as stroke, and E means eyes. Sudden onset development of the blindness, and F means face, facial, sudden development of the facial asymmetry. A means arms, sudden onset of the arm drop, and F means speech, sudden onset of the aphasia, dysphasia, or slurring of speech. Then we can say this is development of the stroke, and and the development of the severe vomiting and severe headache. This is the symptoms of stroke. And T means time. Time is very much important. We all know that every 1.9 million neurons die within 1 minute in a hyperacute stroke patient. So every single second is very much important for the hyperacute patient. The symptoms of stroke is, we all know, hemiplegia, monoplegia, dysarthria, visual disturbance, unconsciousness, imbalance, body weight, etc. But stroke means we can see focal seizures with post-ictal hypoglycemia, drug poisoning, hyponatremia, migraine, functional, brain tumor, brain abscess, encephalopathy, dementing disease, etc. And for a diagnosis of the exclude, we can exclude this. We know the types of ischemic stroke and hemorrhagic stroke, and definition of the acute stroke is patients presenting within 6 hours of rapidly developing clinical signs of focal disturbance of the cerebral function. And we did a survey on stroke patients in Bangladesh 2017 in collaboration with DJs and Institute of Neuroscience. And we know the stroke prevalence in Bangladesh from the survey 2017. And ischemic stroke 80%, hemorrhagic stroke 16%, and subarachnoid hemorrhage was 4%. Common risk factors of stroke in survey 2017 from the survey, we know hypertension 79%, diabetes 28%, ischemic heart disease 20%, dyslipidemia 39%, smoking and tobacco 37%, atrial fibrillation 14%, pulmonary heart disease 1%, obesity 9.9%, lack of fruits and vegetables 67%. Prevention of the stroke, maintaining a healthy lifestyle or modification of lifestyle, avoiding smoking, avoid alcohol intake, regular physical activity, dietary modification, limitation of sodium, meats and sweets, regular health checkup. 20% hemorrhagic stroke and 80% ischemic stroke, you know, and the global and regional national burden of the stroke. We know that increasing the incidence of stroke day by day in the world, and Russia and China, we can see a very high incidence of stroke. And from our survey, 2007, the prevalence of 11.4% per 1,000 population, and this is nearly 4 times higher than previously published report in 2011, and it is higher 30%, 30 per 1,000 among the people aged more than 60 years. And the prevalence of stroke among 2 times than females. And from the survey, cause of disability is number 1 by stroke in Bangladesh, and secondly in cause of death. And this is alarming for us. 10% of stroke occurs people below the age of 40. That is young stroke is 10%. It is more than other countries of the world. And the prevalence is very high in Bangladesh. In a neighboring country, India is prevalence 6.74%. And 2017, total 19 lakhs was in Bangladesh. And the prevention of the stroke, the awareness of stroke, access with treatment, availability of treatment, multi-specialty approach, availability of the ambulance, trained personnel, imaging facilities, medication, stroke rehabilitation, activity of the daily living, and stroke in silent epidemic. We need to plan for early identification, train human resources, imaging facilities, stroke rehabilitation with home care management. Treatment options of hyperacute ischemic stroke: thrombolysis, that is IV thrombolysis and intraarterial thrombolysis, mechanical thrombectomy. Tissue plasminogen activators in the treatment of acute ischemic stroke from the ASHA guideline or AHA guideline. Says early management of the patients of hyperacute stroke by altiplase. And 9th guideline also altiplase is recommendation for hyperacute ischemic patient within 4.5 hours. and also the New England Journal of Medicine, thrombolysis with altiplase 3 to 4 hours after acute ischemic stroke. Facilities required for the thrombolysis. First of all, rapid patient recognition and reaction to stroke warning signs. Then we call the emergency medical service, then transport, then we reach the hospital emergency department, then we did CT MRI and treatment by the stroke physician. There is golden hour, it's 10 minutes from arrival or evaluation by the physician. Less than 15 minutes, stroke or neurologic expert is conducted. Less than 20 minutes, CT scan or MRI, and less than 4.5 minutes or sooner, interpretation of the neuroimaging, and less than 60 minutes, initial and the ideal treatment. Primary should first of all recognize the stroke in time, either treat or refer urgently, and 80 minutes counts in every 6 hours. We see the this is the necrous tissue core. We say this core and penumbra and oligemic. This two area is salvageable tissue. We can salvage this tissue with altiplase or thrombolysis. An untreated patient, 1.9 million neurons are die every minute in the ischemic area. When it comes to stroke, time is brain. With stroke, time loss is brain loss. That is every second counts. CT or MRI is a must to differentiate between infarct and hemorrhage and to rule out stroke mimics. In most hospitals, it is in the gold standard. MRI should not delay because the stroke treatment. CT scan, we can rule out the brain hemorrhage by CT scan, first of all. In first 6 hours, CT scan is usually normal or shows sulcal attachment. Only there is no sulci. Early signs of hyperacute stroke is hypertension of brain tissue, obstruction of the lentiform nucleus. This is the hypertension of the cerebrum and the obstruction of the lentiform nucleus and insular rebound sign. And that is dense and shear sign. And that is lots of sulci. We do the expectation during thrombolysis, M1, M2, M3, M4, M5, M6, and caudate nucleus, lentiform nucleus, insula, and internal. So there is every area is every point counts, total 10 points. We do the thrombolysis 7 or more than 7. Post-solution is to also total points is 10. We can thrombolysis when expectation 7 or more than 7. Urgent workup is Glasgow Coma scale. First of all, airway clear, then breathing and respiratory rate and oxygen, then circulation ensure. And first of all, immediate IV channel will be open in 2 arms. For one arms for normal saline and others for thrombolysis. And we send the blood for CBC, RBS, creatinine, electrolyte, and blood grouping to the respective department, and fluid bleed ECG done by the duty staff nurse. And urinary indwelling catheter will be inserted, but no nasogastric tube insertion without recommendation. There is NSS score. NSS score, there is, we know that total NSS score is 30 points. Total 11 domain. We need 224 point for thrombolysis. We do the non-conscious CT scan as early as possible, but CT angiogram sometimes needed. When arterial hypertension patient with acute ischemic stroke, we need blood pressure less than 185 and 110. But if there is blood pressure of more than 185 by 110 of the patients, we give the levodopa 10 to 20 milligram IV start over 1 to 2 minutes. Then we can wait 15 minutes. After 15 minutes, we measure the blood pressure. If blood pressure lowered 185 by 110, then we can do the thrombolysis. But it not lower the 100 blood pressure, then we again give the levodopa 10 to 20 milligram. Then we can again wait 15 minutes. If blood pressure lowering 185 by 110, then we can do the thrombolysis or not less than 185 by 110. We exclude the patients from the thrombolysis. RTP administration protocol is 0.9 milligram per kg body weight. First of all, we can give the 10% in loading dose and other 90% give intravenous infusion over 1 hour. We post RTP care for 24 hours, strict neurological observation, watch for bleeding tendency, no heparin or heparin antiplatelet, no catheter and G-tubing intraarterial catheter. Blood glucose, electrolyte, urea monitoring, and cardiac monitor for at least 24 hours for detect atrial fibrillation or other life-threatening arrhythmia. IV thrombolysis is needed as quick as possible for an hyperacute patient. This is actually risk of arterial bleeding, anaphylaxis, embolism, and toxic anemia. But in our hospital, we found only bleeding, some symptomatic bleeding and asymptomatic bleeding. Management of symptomatic intracranial bleeding occurring within 24 hours after an extra high-velocity place is to first of all high-velocity place infusion. Then we send the blood for CBC, PTA, PTT, 15 level, and type and cross-matching, and then do an emergency non-contrast CT scan, and we give precipitate 10 unit, and after that 10 acid 10 vial, that is 1,000 milligram IV infused over 10 minutes. Then we consult the hematologist and neurosurgery consultation, and supportive therapy, management of the blood pressure, intracranial pressure, cerebral perfusion pressure, temperature, and glucose control. Evaluation of acute ischemic stroke. First of all, introduce 1995 streptokinase, and then trial with desmoteplase, alteplase, 2009 from, and now study going on tenecteplase. We will try tenecteplase in future in Bangladesh. Means thrombolysis protocol, and our protocol is, the slogan is Almar at the door. And inclusion criteria of our protocol: age 18 to 80 years, time within 4.5 hours, non-hemorrhagic contractility, and aspect score 7 and more than 7, and NH score 4 to 12. And exclusion criteria, absolutely exclusion criteria when stomach is more than 4.5 hours, and any coagulopathy, and hypoglycemia that is less than 2.8, and hyperglycemia more than 22, and age less than 18 years. Hypertension, that is systolic 185 or more than 185, and diastolic 110 and 110, more than 110. Pregnancy and severe comorbidity and dementia. Contradictions, patient reaching after 4.5 hours of symptom onset. It can reverse internal hemorrhage, ischemic stroke within 3 months. Get injury, intracranial surgery within 3 months, and intracranial hemorrhage, subarachnoid hemorrhage, bleeding with the first 21 days. In our protocol, now it is the summary. First of all, patient with acute neurological deficit available in the emergency department, and then clinical assessment by the emergency physician, suspected stroke, Then we do the non-contrast CT scan, and if assess eligibility for the use of IV RTPA is more than 18 years, technical diagnosis ischemic stroke, and the time is more than less than 4.5 hours, then checked for contraindication or relative contraindication. Free thrombolysis evaluation by NSS code 4224 and obtain informed consent. Thrombolysis with alteplase, first of all, it's the IV RTP dose for 9 mg per kg, 10% bolus and 90% remaining over 1 hour. Then post-thrombolytic follow-up. Data of thrombolysis in our history unit, that is the first thrombolysis in history unit in Institute of Neuroscience, and 12 November 2019. There is data of thrombolysis. Then we can see that both needle time is 15 minutes, 30 minutes, 25 minutes, 25 minutes. But our golden hour is 60 minutes. In our study, 40 minutes, 30 minutes. Up to 24th April, we did thrombolysis to 110. Total number of ischemic stroke patients approached for thrombolysis 450. We thrombolized 210 and improved 172. Remaining is 24 and deteriorating or died 14. In our hospital, our limitations, challenges in practice of CT perfusion and practice with lateral thrombolysis and practice of mechanical thrombectomy. 31. A 65-year-old patient presented with right-sided weakness and inability to speak for 3.5 hours.
সাদিক ভাই একটু হাত উঁচু করতে বলেন। বাম হাত উঁচু করেন। সাদিক ভাই একটু উঁচু করেন। সাদিক ভাই একটু হাত উঁচু করতে বলেন।
NSC score before thrombolysis 17, Glasgow Coma scale is 13, and pulse 88, blood pressure 140/90, upper limb right side 1/5, lower limb right side 1/5. Aspect score is 7. Free thrombolysis aspect was 7. Patient fulfilled all the criteria, so intravenous thrombolysis was administered. And now, can you guess the outcome after 24 hours?
অন্য পাশের পাটা তোলেন। ঠিক আছে, রাখেন রাখেন। আপনার বাম হাতটা তোলেন। ঠিক আছে, রাখেন রাখেন। ডান হাতটা তোলেন পুরোটা। ঠিক আছে।
After 24 hours, upper limb right side 5, lower limb right side 5/5. And after 48 hours, and is good for Glasgow scale 17, upper limb right side 4/5, lower limb right side 5/5. Is it to a 38-year-old patient presented with left side weakness and facial asymmetry for 4 hours?
উপরে ছাদের দিকে তাকান। চোখ বন্ধ করেন, হাত মুঠ করেন, খুলেন। দুই হাত সোজা উপরে তুলেন, দুই হাত সোজা উপরে তুলেন, ধরে রাখেন। 1 2 3 4 5 6 7 8 9 10। ওকে, ফাইন, রেখে দেন, রেখে দেন। গুড। আবার আপনি এই পা তুলেন, না ডান পা তুলেন, ধরে রাখেন। এখন বাম পা তুলেন, বাম পা। 1 2 3 4 5 6 7 8 9 10।
Before thrombolysis, and is score 5, and upper limb right side 5/5, lower limb right side left side 4/5, upper limb left side 4/5, upper motor neuron lesions in facial palsy left sided. Aspect 10, and patient fulfill all the criteria to show intravenous thrombolysis was administered. Now, can you guess the outcome? After
হাত রেখে দেন, সবাই দেখে আসেন। এখন কেমন আছেন? ভালো আছেন?
limb left side 5/5, and lower limb left side 4/5. Aspects 10, post thrombolysis, CT scan, CT angio normal, and discharge after 24 hours.
দাঁত দেখান, দাঁত কেমন আছেন এখন? একটু কষ্ট করে দাঁড়ান, দুই হাত সামনে তুলেন, কেটে আগায় আসেন। ঠিক আছে।
Facial palsy corrected, left side 5/5, and lower limb left side 5/5. Patient's review.
আমার বাবা স্ট্রোক করছিল, স্ট্রোক করার 4.5 ঘন্টা পর আমরা নিউরোসায়েন্স হসপিটালে নিয়ে গেছিলাম। 4.5 ঘন্টার ভিতর ওরা ওইখানে থ্রম্বোলাইসিস করছিল, চিকিৎসা দিছিল, যার কারণে আমার বাবা এখন একা একা সব করতে পারে।
আমরা যত দ্রুত সম্ভব আমরা নিউরোসায়েন্সে চলে আসছি, এবং নিউরোসায়েন্সে আসার পরে ডক্টররা আমাকে এই মানে থ্রম্বোলাইসিস দেওয়ার কথা বলে, এটা নিতে হবে। মানে ওরা টাইম হিসাব করে দেখে যে আমি রাইট টাইমের মধ্যে পৌঁছাই গেছি, তখন ওরা আমাকে চিকিৎসাটা দেয়। এবং আমি গত পরশুদিন থেকে এখনো অবধি অনেক চেঞ্জ নিজের মধ্যে পাচ্ছি, এবং আমার যে ভাগটা ছিল সেটা আর এখন নেই। আলহামদুলিল্লাহ অনেক ভালো আছে। সত্য বলতে মনে হচ্ছে যে আমাকে নতুন করে বাঁচাতে
Means that tertiary hospital for stroke, and this is a primordial and primary prevention under an excellent stroke unit. Prompt notification and response of emergency medical service, acute stroke treatment including the hyperacute and emergency department phases, subacute stroke prevention and secondary prevention and rehabilitation. And gender distribution admitted patient 2021, total male patient 2018, and female 1858. Stroke unit 100 bedded with 100 cardiac monitor, 24-hour CT scan facility, 24 hours active emergency department, dedicated stroke physician and nurse, 24/7 immediate stroke response team, and door to needle time is less than 60 minutes.
National Institute of Neurosciences started its journey of September 2012. Since its inception, it has been playing a very vital role in treating and other neurological diseases. As a continuation of 800 unit is divided into two separate units.
I think it's a technical issue. Our speaker somehow left. Is there anyone from Planetary Health Academia?
Assalamualaikum, ma'am.
Alaikum assalam. I think our speaker just kicked off. I don't know how. Would you mind trying to make him come back?
I think he's facing internet issue, ma'am. Just give me a minute, ma'am.
Thank you. Sorry about the technical issues. If you have got any questions, just drop that question in the chat box. We'll try to answer at the end of our talk. Oh, he's back. Good. Oh. Yes, good.
Yeah. Good.
Hello. I think he's muted. We can't hear him. Hello.
Hello.
Yes, we can hear you now. I think for a short period of time, you just got out of. Yeah, sorry about that.
Sorry for technology problem.
I think we have seen some part of the videos you're showing about the names. So
Okay,
do you
okay.
mind? Yes, we
Oh.
have missed rest of those.
Okay, okay, okay. Thank you very much. Again, the National Institute of Neuroscience, did you?
Exactly. That's great.
আমার বাবা স্ট্রোক করে
আমরা
National of Neuroscience.
Yes, that one. Right.
In treating stroke and other neurological diseases. As a continuation of exercise, a dedicated stroke unit has been inaugurated recently. The stroke unit is divided into two separate units, male and female. Also, it is equipped with all modern and sophisticated technology. Each bed has separate advanced patient care facility for a world-class service.
This video is not moving, just stuck on one side.
Care professionals are committed to work tirelessly for the stroke patient.
Now we can hear.
National Institute of Neurosciences, 100-bedded stroke unit, and a new hope for stroke treatment in Bangladesh.
Okay, thank you
Yeah,
very much.
Okay, that's great. Thank you
Okay,
very
okay,
much
thank you
for
very much.
your talk. Yes, it is very well presented, very comprehensive, and I'm very excited to know that in NINS, we have already done 210 patients for thrombolysis therapy. It's really, really promising. I would like to know what are the main barriers you are facing doing thrombolysis over there? Hello?
Hello?
Yes, now we can hear you.
Hello? Yes.
Can you hear us?
Hello?
Yes, can you hear us?
Yes, yes, now I am hearing.
Okay, that's great. Yes, actually, I would like to know what are the main barriers you have faced so far? And this discussion is open to all. I'd like to have more discussions, more participation with that question.
I already discussed about our challenges, but main challenges is awareness.
Yeah, correct.
And second is economy constraint for our patients, because Bangladeshi 50,000 taka is need for thrombolysis. And third is informed consent, where some patients cannot give the consent, and other challenges is average for stroke management.
So for overcoming these few barriers, because I know to create awareness is not easy in our country, so there are lots of issues going on. So what are the steps you have taken so far?
We can trying our best for like this semi program, like electronic media, like print media, like version. Then is another our student, our doctors community to deliver the thrombolysis, and by this time thrombolysis in Bangladesh, already few patients already they did thrombolysis in their center.
Okay, and what are the other centers doing thrombolysis at the moment? This question is to Professor Narayan, sir, please.
I cannot get your question, please. Can you repeat it for me?
Yes. What are the other centers, both government and private sectors? What are the other centers they're doing thrombolysis at this moment?
I don't have exact figure, but what I came to know, it's going on in Chittagong Medical College. They have started recently. It is happening in few private centers like Evercare Hospital, United Hospitals, and possibly in Sylhet, they have started 1 or 2 cases for this thrombolysis. So a bit
and
restricted.
Bangabandhu
Yes.
Hospital.
Yes, definitely. It's in the Bangabandhu Medical College Hospital, as well as they are doing this thrombolysis.
That's great. And is that thrombolysis going on in Shohid Sohrawardi Medical College as well?
It's not there. Actually, it's a very limited scope is there. And we do have manpower limitations, as well as that technically knowledgeable persons are not available at this moment. It's government has extended its infrastructure. Possibly in next coming years, government can develop such infrastructure. Then it will be possibly can be delivered to the patient as well.
Okay, that's great. Dr. Pradip Shaha, he has asked about, is thrombolysis available 24/7 in NIMS?
Yes, we can available in 24 hours every day.
That's great.
Our
And yeah, yes, go on.
Always ready.
Sorry, we missed out your sentence. What was that? Can you repeat the last sentence for us, please?
24 hours thrombolysis, 24 hours facility for thrombolysis is available in our NIMS. Our stroke response team is always ready for thrombolysis in every day, 24 hours.
Oh, fantastic.
24/7.
Fantastic. And what about mechanical thrombectomy? This question is to Kazi Mohibur Rahman, please. So I can see in the chat box that around 7 cases of mechanical thrombectomy have been done. So what about the service of mechanical thrombectomy there? This question is to Professor Kazi Mohibur Rahman. I can see that in the chat box.
Okay. Mechanical thrombectomy facilities available in our NIMS, always available, but for economy constraint and for awareness, there is we already did 2 or 4, I think 4 mechanical every patients use the mechanical thrombectomy hospital. Maximum patients are poor. They are rickshaw puller or garments worker or very poor person, poor patients came our hospital for admission, and they have no effort for mechanical thrombectomy.
How much the cost for mechanical thrombectomy? Is there any estimation for that?
I think 3 or 4 lakhs in Bangladeshi taka needed.
That's probably not affordable to for everyone. Yeah. Audience, you can ask question if you want. And actually, I'm not quite sure if Professor Kazi Mohibur Rahman has got the access to our chat, because he's writing that he can't hear us. What about the admin team? Would you mind trying to find out if or not? Hello? Yes, we can see you.
But I can hear very faintly. Actually, the presentation was very good, and the studying IV thrombolysis, though it is not new in the world, but for us it's very new. For having a total comprehensive step in it, we need both IV thrombolysis and arterial mechanical thrombectomy. We have a very good intervention neurology department, but due to our procedures, government procedure,
We just stuck again. Probably internet issue, probably.
we did 7 mechanical thrombectomy. The first patient was she died. Now rest of the day was good. When it's my personal feeling, when we can start this mechanical thrombectomy is the main stream main choice to treat the patient, but as well as it was not started before we started at NINS. We need to start in the other centers of Bangladesh where there a good number of neurologists are available, such as BSMMU, Dhaka Medical College, Chittagong Medical College. There are quite 5 to 7 neurologists there. At least office hour, we should start doing the IV thrombolysis. There are some difficulties to start the procedure is the lack of awareness. Still, people think stroke is the disease of the heart, not the brain. Very good number of patients usually go to the NICD, National Institute of Cardiovascular Disease, treat the stroke. And the jam in the street is very horrible in our country at the daytime. The patient is 2.5 hours time. I think in future, our young neurologists will come. In my department, around we have 11 doing intervention, out of which 7 are young neurologists. I will welcome the young neurologists to come to our department that can flourish the subject eventually.
Is mechanical thrombectomy available for 24/7 in NINS? No, not at this moment.
Yes, that is in the office around from 8 to 2:30 p.m.
Okay.
8 in the morning to 2:30 p.m.
Okay. And who are doing those mechanical thrombectomy? Is it interventional radiologist or neurosurgeon?
Intervention neurologist in our means.
Intervention is doing by, we are total neuro. At present, we are 13 interventions being the process. And we are busy with aneurysm, coiling, ADM embolization, same kind of jobs that we are doing right.
Yeah, I think consenting is also another important barriers to our to the thrombolysis in our country's perspective, isn't it? Because most of the patients probably they are not quite get it. What about the thrombolysis and thrombectomy therapy? So, what are the obstruction like features you have got while consenting the patient?
Initially, the thing was the availability of the material. Now it is available in our hospital, but we didn't get the patient within the time our office hour. That is the main problem. Hopefully, we get the patient. We have done 7 out of 6 patients had a good NHS score, and everyone has a M1 block. And another thing is one patient he didn't cannot recognize the thing. Sometimes the time frame patient stated is not actually the true event. Maybe the time has elapsed, say maybe 8 to 9 hours, but patient was saying that can understand for 4 hours. In that case, the clot will organize and it will not come, cannot take it out. That was we feel the problem. That was a partial recolonization. The patient has good results. That is why he had a good outcome. But these things are also a problem. But at present, we are ready to the mechanical perspective within this time, from 8 morning to 2:30.
2:30. Okay.
Except
okay.
Friday.
Except Friday. Okay. Okay. Yeah. What are the this question is to Professor Naran Chandra Kundu. What are the steps do you think we need to take to make thrombolysis available to all government sectors in our country? Because you are working in Shwetharadi Medical College, it is one of the important medical college in Bangladesh. So what do you think about that?
Okay, it has two prospects. One is the awareness and training, and awareness should be done by a mass propaganda by the Society of Neurologists, government and non-government organizations. We do not have a huge propaganda regarding these modalities of treatment right in Bangladesh. So there is sporadic activities, but not an organized activity, right? Number two, the people should be aware where to go so that they can go to the right place. In many of the situations, the people rush to the cardiology hospital before being referred to the neurology hospital. So this propaganda should be through and through so that people can be aware of the symptoms. And the emergency medical staff should be properly trained, especially to exclude the stroke mimics, right? So if they can exclude, then they can refer the patient for imaging, and the imaging should have a dedicated section so that there is no delay. And at the same time, the CT protocol should be revised so that at the same CT scan, they should go for a perfusion scan as well. And this is a huge investment, and I don't know whether government can invest such a degree to make it available to all people of Bangladesh. But the society again should pursue for it so that the government involved here and invest for the general well-being of her people. And for regarding the treatment plan, it should be a team rather than only neurologist. So a team should consist of a neurologist, a counselor as well, so they can make the patient understand what is going on, what is the risks, and how it can help the patient party or patient to get rid of it. And it should also include a neurointerventionist and as well as neurosurgeon if anything deviated from only from the thrombolysis, so that can be dealt immediately. And it should be a teamwork. And finally, government should fund. As Professor Johilak mentioned, it costs some 50,000 taka or more. Many of us cannot provide who attended the government hospital. So there should be some subsidization from the government as well. And so part can be bared by the party and part can be bared by the government. And overall, the people who are working, who will be working, even the staff, the doctor, should have a separate payment system so that they can work round the clock. And this will be huge tax, and that should be dealt with the society, not by the common physician or common people. And here is Professor Johilak, who is a part of the Neurology Society. Professor Mohibur is there. So they should take an orchestrated effort so that government invest here.
Absolutely. I'm just going through the chat box. Dr. Pradipto Saha has asked, is there any chance we can do both thrombolysis followed by thrombectomy?
We'll answer it.
Is there any way we can provide both thrombolysis and thrombectomy to a patient?
This is a question to me.
It's to everyone, whoever is picking it up.
Yes, it could be. It could be because in
So
cases there are
both
scenario.
IV thrombolysis and intra-arterial thrombolysis, mechanical thrombectomy, if needed, if there is a amount occlusion, in that case, mechanical thrombectomy is needed, and the combination of IV thrombolysis and mechanical thrombectomy is a better outcome than only the single treatment option.
Okay, and how far we are to get that in NINS? Is there any way we can establish this thing in NINS, like thrombolysis followed by thrombectomy? Hello? Hello? Can you hear me? Am I clear to everyone? I mean, am I audible? Yes, Dr. Manumendra Bhattacharjee. Yes. What's your question, please? I can see your raised hand.
Yeah, can you hear me?
Yes, we are hearing you.
Thank you very much. My question, two questions actually. So first question to Professor Dr. Mohammad Johirul Haq, and the second question to Professor Qazi Mohibur Rahman. Johir bhai, can you hear me?
Yes.
Yeah. My
Yes,
question
please.
is, in the cases where the patients don't have any immediate access to the MR or CT angiogram, in that regions where we only rely on the plain non-contrast CT scan. If the patients come within the 4.5 hours time interval, in that cases, would we actually rely on the aspect score of the patients, or without bothering the aspect score, we can go straight to the thrombolysis? Because the aspect score is always there is a inter-observer variability, there possibility of the inter-observer variability. In that cases, can you recommend to start the thrombolysis without bothering the aspect score, just a apparently normal CT scan, and the patients fulfilling the criteria of giving thrombolysis, you will recommend to start thrombolysis or not?
Yes, thank you for your fine questions. We every time we see patients, but in some cases we cannot bother the aspect issue because if time is within 4.5 hours, then other parameters is in favor of thrombolysis, we can do. But in some cases when we see the patient is 0.5 hour is confusional state and confusional state, loss of consciousness, and then when we suspected to proximal occlusion, and then we can do CT angiogram or
No, I am
or
Johid bhai, I
confusion.
just I was talking about the whether we don't have any immediate access to the MR angiogram or we don't have any immediate access to the CT angiogram. But if this patient is fulfilling the criteria, that is the NIHS is within the 4 or 22, that this patient is eligible for giving the thrombolysis. In that case, should we bother the aspect score or not?
Yes, aspect is very much important because when more than score is we guess the stroke is very much large. In fact, is very much large. Then we can do the thrombolysis.
Okay. My second question to Dr. Kaji Mohibur Rahman. Can you hear me?
Yes, I am hearing.
Okay. My question to you that if you have these patients of the acute stroke and these patients come within the time period and you have the opportunity to do the CT angiogram of the patients, if this patient's showing the very large vessel occlusions, that is the M1 occlusions, these patients doing the CT angiogram in this within the time, and in that cases, will you go straight to the mechanical thrombectomy or you first to do the thrombolysis and then for the mechanical thrombectomy if this patient is the M1 occlusion?
Better option is combo. Start IV thrombolysis and do the mechanical thrombectomy. This is the standard choice of treatment.
Thank you.
One question from chat box: is there any chance to use tenecteplase instead of alteplase? I think they are now in the pipeline.
It is not available in our country. We have to depend about within our resources. No?
Definitely. Yeah. In case of obtaining consent, what are the difficulties you are facing, like in terms of like explaining your?
One of main is the cost. Main is the cost. But there is no insurance system in our place. That is why sometimes it's difficult to do the thing, but there are some options we can do. It is the academic case or the patient is poor. We overcome those situations in those things. And government has given us the very subsidized price to do the procedure. The coil right now for a coil it is 80,000 taka, Bangladeshi taka, but government price is only 7,000. In a for a mechanical thrombectomy we can give free of cost. That is the option is also in our hand. Other than think patient we approach those 7 cases and all are agreed to do the procedure. From the patient there is no difficulties. The problem is the cost.
Okay, that's great to know. Yeah, the cost probably the main barrier now. Okay, that's great. Okay, that's okay. Is there any other questions from the audience? Okay.
But
I think it is all.
Can I leave, please?
Okay, okay. I'm trying to wrap it up now. If no one
Okay,
is asking.
thank you all. Thank you.
Okay, that's thanks. That's great. Thank you very much for your time. Okay. I would like to ask Professor Narayan Chandra Kundu. Would you like to say something for us?
Thank you, the organizer and the rapporteur for conducting this very informative session. I thank Dr. Jorul Haq for his elaborate presentation. But what I want to say, this is a picture of Athens, but doesn't reflect the entire Bangladesh. So this is not the perspective at present of the picture of Bangladesh. This is a perspective at means. So we should go far beyond. We should make it more generalized. We should keeping up our effort so that a patient who is at Rajshahi cannot reach neuroscience by 4.5 hours. So it should be it should spread at least at the divisional hospitals so that people get treatment which is more a definitive outcome is much better than the conventional treatment. That's what is from me. Thank you very much once again.
Thank you, Professor Narayan Chandra Kundu, and thank you, Professor Johil Haq Chaudhuri, for your valuable time to join us. And thanks to the audience for your lively discussion. We'll see you again for our next session. Thank you. Till then.